Hi, this is E. David Crawford, Editor-in-Chief, Grand Rounds in Urology. Joining me is Dr. Dan Lin, who is Chief of Urologic Oncology at the University of Washington, Department of Urology in Seattle. Dan is the lead author on an important paper that was just published in the Journal of Clinical Oncology that looked at the GPS Oncotype DX and a study called the Canary Prostate Active Surveillance Study, the PASS cohort. Dan, tell us about this study and why it is important and your findings, and we appreciate you being with us.
Well, thanks for having me, and I did want to just point out some salient highlights of the study of the GPS score in active surveillance that was just recently published, as you said, in the Journal of Clinical Oncology. I'll take about 5 minutes and just put some highlights and then maybe end with a couple questions and maybe some future directions for the work. So this was a paper that was just in JCO last month, and amongst the whole Canary cohort, and we're well over 1,000 or 1,500 patients, we had about 432 with a GPS score from the diagnostic biopsy. So we went and found the diagnostic biopsy, and we did the GPS score on that. And of that, almost 40%, 167 patients, had an upgrading event and a subsequent biopsy, which is predicted for the natural history of active surveillance. About 101 of the 432 had a radical prostatectomy, and just over half had adverse pathology, which was defined as primary pattern 4, any pattern 5, or T3A or N1 disease. And then we had a multivariate model, which included all clinical data, so that would be PSA density, number of cores, PSA, and so forth. And just cutting to the chase, the primary endpoint was adverse pathology, and GPS was not associated with adverse pathology. The hazard ratio of 1.17, the p-value was trending. It was 0.066. For a secondary endpoint with any reclassification to a higher grade group, the GPS was not associated with any subsequent upgrading, and you can see there the hazard ratio was basically 1, the p-value of 0.48. This is the data, right? I think this is the sort of the money slide. If you look at the association of adverse pathology, the first model was just GPS with Gleason grade, which is the base model that the company uses, and it was significant. But if you layer in PSA density, a log PSA density, a continuous variable, you see that the p-value is attenuated. Again, it's trending, it's 0.066. And when you look at what we call the predictiveness curves, which I think really show things the best, relative best, you see here, and the way these are read is this is the estimated 2-year risk, and the disease prevalence is here. And the way this is read is the farther away from this line the curve is, the better. So the blue line right here is GPS with Gleason grade. That's that model. That's what the base model the company uses. The red is just clinical variables. So this red line is just PSA density and Gleason grade group. That's what we call the base clinical model. If you layer on top of that, the green is the layering on top of that with GPS. You can see there's very minimal difference between the dotted red and the green, except for perhaps up here in the higher risk population where GPS does appear to have a little bit more separation. We've been somewhat criticized for the event rate. I mean, in this 101 patients that had a prostatectomy, there was 52 of those had adverse pathology. If you think about 52 of the 432, it's about 12% event rate. However, when you really think about statistical modeling and the way we have study power is calculated on number of events, not event rate. And so any clinical trials would tell you that that's how we calculate study power, number of events. The primary endpoint for this study was powered on 65 events, and we have 52. The question I would always ask is, if we went from 52 to 65, would that make the p-value significant? Probably, it could. But my point would be that if there's not clearly statistical significant signal at 52 of the 65 events, then more events are really unlikely to have a clinically meaningful impact. And many biomarker study groups would suggest that hazard ratios of less than 1.5 or 1.7 for biomarkers are really not clinically significant. And in this case, it was 1.17. Another criticism of the study which we should address is that it was too low risk population. So in our study population, it was largely low risk, but 25% were intermediate risk in the patients undergoing radical prostatectomy, and 20% of the 432 were intermediate risk. So 1 in 5 had intermediate risk disease. It was not all low-risk disease. And we did include patients with high-volume grade group 1. Others would say that the sweet spot for this type of a test is in the intermediate or high-volume Gleason grade group 1. However, to my knowledge, there's no data for the use of GPS in large cohorts of men with intermediate risk disease or high-volume grade group 1 undergoing initial active surveillance. Lastly, others would point to, and I think we should look at, the data that support the use of GPS in this setting. And there was one large study. It was over 200 men undergoing prostatectomy after initial starting on active surveillance, and this was the Kornberg study. Again, a single center study of GPS to predict adverse pathology. When you really look at the methods, it had a very heterogeneous group. Some of the GPS tests were performed on the diagnostic biopsy, and others were performed on a subsequent biopsy. Some of the GPS tests were part of clinical care, and others were according to a strict research protocol. And again, these are data directly from the paper, a table directly from the paper. You can see that GPS certainly was associated with adverse pathology. Again, that hazard ratio looks very similar to ours at 1.16, but it was significant. When you look at the other data, the most supportive and the factor for adverse pathology was whether the GPS was performed on the confirmatory or the diagnostic biopsy. And the highest hazard ratio at 2.42 was whether the GPS was performed as part of clinical care or part of a strict research protocol. Again, suggesting bias that's introduced in ordering the test as part of clinical care that would weight it artificially towards the GPS being significant. And again, I think the bias in this study is significant and unmeasured. Lastly, just some take-home points. Again, biomarkers we feel should be used in the context of existing clinical variables. Specifically, start with clinical variable model, add on a biomarker to see whether that works better. Because in this case, although GPS is probably independently predictive of adverse pathology, there is no statistical significant association of the GPS with adverse pathology at surgery or upgrading when included in a model with those readily available clinical variables. And again, I'll just emphasize that it just minimally improved the risk stratification on those curves, and it also included men with grade group 2 as well as higher volume grade group 1 disease. I'll end with some questions, and I think that I'll leave it here. These are largely unanswered. And what are the appropriate endpoints for active surveillance? Is it upgrading? Is it adverse pathology? These are open questions. But most importantly, how do we incorporate clinical models into the practice of surveillance? In other words, we already know that PSA density or number of cores, BMI in some reports, are associated with upgrading or adverse pathology. How do we actually use that in everyday practice? And more importantly, for the sakes of this paper, how do we incorporate biomarkers on top of all those known variables and operationalize the biomarkers? Thank you for your attention.
Hey, Dan, thanks a lot for that great point presentation. And now we're going to hear a counterpoint on the 17 gene genomic prostate score results from the Canary Prostate Active Surveillance Study, PASS cohort. I'm happy to welcome Dr. Eric Klein, who is chairman of the Glickman Urological and Kidney Institute, the Cleveland Clinic, professor of surgery, Cleveland Clinic, Lerner College of Medicine, a good friend who has been a pioneer and leader in so many areas in urologic oncology, and also a lot of the seminal work that has been done with molecular markers has been with Eric. So Eric, we're anxious to hear your view of this Canary PASS study. Thanks for being with us.
Yeah, thanks for having me, David. This is a very interesting area. First, I want to congratulate Dan and the authors for doing the study that they did. We certainly need these sort of studies to understand how to use these genomic tools and other biomarkers. So I have a number of thoughts about the study and differ, as you probably won't be surprised, with Dan on the interpretation. The first thing I'd like to point out is that the conclusion of the Canary study is at odds with a great study that was published by Peter Carroll and colleagues at UCSF in the October issue of the Journal of Urology. In fact, I think, oh no, that was a different article that was on the cover. This wasn't on the cover, but it's a very similar sort of thing. This was to test GPS for the prediction of adverse pathology in a series of active surveillance patients, just like Canary was, over a very similar time frame. And the conclusion was the exact opposite. And so I got to read the conclusion because I'm looking at the paper right now. This is the conclusion from Dr. Carroll's study. In patients who undergo radical prostatectomy after a period on active surveillance, as in those who undergo immediate prostatectomy, a higher Oncotype GPS score is associated with an increased risk of adverse pathology. And the GPS score was also associated with biochemical recurrence following radical prostatectomy in both cohorts. So before people dismiss the use of these tests, it's important to consider all of the published data and to try and understand two studies that came to opposite conclusions and what's different about them. And so a couple thoughts about the Canary study in particular. First, the Canary study relied on local pathology biopsies. It was a multi-site study, and there were a lot of non-expert pathologists who read the pathology there. So we can't be absolutely certain about the grading, unlike at UCSF, where they have expert GU pathologists. And we've learned critically in the last few years that the identification of pattern 4 disease and the reclassification of small cribriform glands into pattern 4 and even large cribriform glands into pattern 4 and so forth. So that's a problem. The Canary study goes back to the mid-2000s where those things weren't recognized. So not having central review, I think, is a major limitation. The second thing deals with event rates, and Dan addressed this a little bit, but there were only 52 upgrading events out of 432 patients who had evaluable tissue. So the event rate was only 11.8%. And if you look at it as sort of an intent to evaluate this test kind of approach, there were only 52 events out of more than 1,000 patients. And so that's only a 5% event rate. So if you think about this, if you were doing a therapeutic trial comparing one drug to another drug and your event rate was only 5% or 12%, you'd have to have a drug that had a huge effect on the order of 50 to 80% improvement in survival. And that's pretty rare. Dan commented in his slides that the study was powered based on the number of events rather than the event rate, but he assumed that this test would improve our predictive power for adverse pathology. Hazard ratios around 1.5, 1.7, or make us 50 to 70% better, but that's not what the published data shows. Published data shows that these tests improve our ability to predict adverse pathology by around 10 or 15%. So in my opinion, the event rate was simply too small to really evaluate this. But then let's talk about the population of patients that were included in Canary. This was really a clinically low-risk population. How do we know that? In the Canary study, 27% of the patients had insufficient tumor to perform the Oncotype test. And what that tells you is that a quarter of the patients probably had a microfocus of Gleason 6 disease. And we know that the likelihood of someone having a microfocus of Gleason 6 disease, so little tumor, and let me reemphasize, you only need 1 millimeter of cancer to be able to run this test, 1 millimeter of cancer on 5 slides. There must have been so little cancer on these that these are really clinically insignificant tumors and they're not at risk for progressing. And so I want to talk about a little bit of unpublished data. So to be fair to Dan, he hasn't seen this data. We're working on getting it published that really put this in perspective, and particularly this clinically low risk group. It's really striking to me that the mean GPS score on the biopsies in the Canary study was 21, and the mean GPS score on the radical prostatectomies that were done was 20.5. It was actually lower than it was in the biopsy. Now, I don't know of any other clinical series where that's been the case. And here's the unpublished data that we have. We now have 20-year outcome data for metastasis and death on the original Oncotype cohort, a little over 500 patients that we did here at the Cleveland Clinic. And the likelihood of getting metastatic disease or dying of prostate cancer with a GPS score of 20 is under 1% at 20 years. So what does that tell you? That tells you that you use a test, here that predicts adverse pathology in a group of patients that's at no risk of adverse pathology. And so I'm going to be provocative here, and I'm going to suggest that this test performed exactly as you would expect it to perform in such a clinically low risk population. It didn't pick up many events because there weren't any events to be had. and that I would suggest that the patients who underwent prostatectomy in the Canary cohort were probably overtreated. Based on their GPS score and our 20-year data, one could say that these patients have an almost 0% chance of running into trouble, and they probably could have been followed for a longer period of time. And so that brings up another point that I think Dan raised, which is that we don't have a clear understanding of what should trigger treatment for patients on surveillance. We traditionally have used an increase in tumor volume, grade 3 to more grade 3, or an increase of grade 3 to any pattern 4, and that's probably way too unrestrictive. There are a lot of patients who go up in tumor volume, and a lot of patients who either had a little pattern 4 that was missed or have developed a little pattern 4 that still have biologically insignificant tumors. And I think the data that I just mentioned suggests that. And one other piece of unpublished data I'd like to share before I finish is that we have from the Canary cohort, actually Dan may have seen this data, I don't know if he has or not, but the pathologist for the Canary cohort is Jesse McKinney, and he's here at the Cleveland Clinic. And he has just submitted a paper showing that in the Canary cohort, GPS score was significantly different between grade groups. So higher grade group, higher GPS score. And that what GPS was able to identify that standard histology, particularly in non-expert hands, couldn't identify is cribriform morphology. And so I think the emerging data suggests that GPS does identify biologically significant tumor, but it's not captured by our usual histologic grading, and again, not in the hands of non-expert pathologists. So I don't agree with Dan's conclusion that this test has no utility. I think our experience is still evolving. You have to put it in context of the patient population that was studied. The long-term data is going to be very informative. And although his last slide said that there's no data or not a lot of data on patients with high volume Gleason 6 and low volume Gleason 3-4 using these genomic tests, that doesn't mean they shouldn't be used. It just means that there's no data, or at least not enough data for him to recommend use for this. We need more data. We need to understand how they work. And again, I'd get back to the Carroll paper, which included some patients with Gleason's 3+4 disease where the event rate was higher. And the conclusion was that the test actually predicted adverse pathology.